Hi, everyone. It is June 28, 2016, and we want to welcome you to today's contribution for the His Health webinar training series. Today we'll be discussing building client rapport and trust, looking at a really fantastic Linkage to Care program in Indianapolis, Indiana. We are very pleased to be joined by Terrell Parker. Terrell is a program manager, hey Terrell, at Brothers United, located in the greater Indianapolis, Indiana area. Terrell has worked in HIV services and prevention for approximately 3 years at Brothers United, which again is a community-based AIDS service organization serving central Indiana's Black LGBT community. Terrell successfully piloted a citywide Linkage to Care program that was implemented by the Damien Center before transitioning into his current role as a program manager and working in a directorial capacity at Brothers United. Terrell graduated from Franklin College in 2012 with a bachelor's degree in English and sociology and hopes to return to school to pursue an MBA as well as future work in health policy. So we want to welcome Terrell so much for joining us for today's training series. So for today, I'm going to start with a little bit of background on His Health, which is what I typically do for some of the newer folks who are joining onto the webinar series. And then I'm going to pass the baton over to Terrell, who will provide a brief overview of the Damien Center and Brothers United's joint Linkage to Care program. He'll also share more about the peer professional model and how it can be leveraged to build client trust with your patients, as well as understanding the tenements of how trust is gained and kept among patients. And then we'll close with a bit of Q&A. So a little bit of background on His Health. I always like to start with talking about the impetus behind developing the resource. NASTAD is in partnership with the Health Resources Services Administration's HIV/AIDS Bureau to create the hishealth.org resource. And hishealth.org is basically an online training platform where providers, both clinical and social, and also public health professionals and advocates can access trainings, resources, and promising care strategies and models of care that prove efficacious in allowing better sexual health service access for Black gay men. In terms of who His Health is and how we identify as a united community of healthcare practitioners and advocates who are passionately committed to uplifting the standard of care for Black gay men. And in order to engender a meaningful shift in the HIV epidemic amongst our patient communities, we believe that we need to start sharing the responsibility, not just among patients, but patients, providers, stakeholders, leaders, and administrators who are operating at every level of our U.S. healthcare system. It's our group responsibility to bring about a shift in the epidemic. In terms of the resources that we will be providing, again, we are developing a cohort or inventory of promising care models that we feel help to advance not just HIV care linkage and retention, but also HIV prevention services and sexual health services that are sex positive and affirming of the personhood of Black gay men. Secondly, a resource that we're developing is a cohort of continuing medical education and continuing nursing education units where practitioners who are looking to maintain their licensure can take courses on PrEP access, STDs, STIs, vaccinations, linkage to care, as well as transgender health that are ensconced in what it means to deliver those particular services in a way that is culturally competent. And third, this resource will be used to disseminate those training materials to as many audiences and advocates and interested parties as possible. And His Health will be launching at the end of this summer, so please stay tuned. So now that I've provided this overview, I want to now pass the baton to Terrell, who will dive into the Linkage to Care program with Brothers United and Damien Center. Terrell, take it away.
Thank you very much. So just wanted to start off by highlighting a few of the things specific to our Linkage to Care program here at Brothers United. The first thing I wanted to point out was that it was actually a partnership grant and a partnership between the Damien Center, which is the oldest and largest AIDS service organization in the entire state of Indiana, and Brothers United, a smaller community organization that has a niche in working with the Black community and the Black LGBT community. Next slide. So this was a 3.5-year research project that was supported by Johns Hopkins University, AIDS United, and the Health Foundation of Greater Indianapolis. The purpose of this grant in particular was to pilot a linkage to care program that focused very specifically on two target populations. We wanted to focus on those who are newly diagnosed, so getting those to those individuals early, within 3 months of their diagnosis, and then also focusing on individuals who are out of care. And our definition of out of care meant no recorded lab work for a year or more. So this was a partnership between Brothers United, Women in Motion, and Indiana Latino Institute. Throughout the course of the research project, we were able to re-engage 187 people. And I think what sticks out the most and what shows our success the most is when you look at the bottom of this slide, the average number of CD4 cells for our clients once they entered the program was 216 versus an average of 528 afterwards, and a reduction in viral load from an average of 52,000 to about 10 copies or less for our clients. So it's very important to highlight some of the successes that we've had in the program, because I do believe that building client rapport and trust has been essential to us having the success so far that we've seen in this program. Next slide. So, more data that just goes towards our effectiveness. 100% of the individuals enrolled in this Linkage to Care program were actually linked to care. Of those, 91% were retained in care. 91%, all of those who were retained in care were prescribed antiretroviral therapy. And what's most impressive and what we like to highlight the most is that we've seen a 70% viral suppression rate amongst our clients compared to 25% of the national average. Next slide. So this is program-level data that just gives you a better understanding of the clientele, the population that we serve. Overall, 49% of the clients were Black, 60% were male, and several of them identified as MSM. In particular, my client load, I would say about 90% of those clients were Black, 90% male, and then maybe 10% trans women. Next slide. A little more demographic information about the clients that we served. The majority of our clients lived in extreme poverty, below the poverty line, and the majority of our clients had a high school diploma or less. Next slide. So, now we're going to get into the meat of the presentation. So what I talked about earlier is that building client rapport and trust is very, very crucial to the success of this linkage to care model, because it's very, very powerful, and it really, really does help to move the client to the next level. So here we're going to talk very specifically about the peer professional model that we implemented and how that's been crucial to our Linkage to Care program and building that client rapport and trust very specifically. Next slide. So one thing that I am very, very passionate about, and one thing that worked very well for our Linkage to Care model, was that it was a peer professional model. We understood that Linkage to Care specialists must reflect the communities that they serve. I talked earlier about this being a partnership grant, and I wanted to delve a little bit more into why this particular grant was a partnership grant. This was the best example that I can think of a coordinated community response to addressing some of the issues and some of the concerns. Citywide, we realized that the Linkage to Care program was not working, that a lot of individuals were being missed. They were not being linked to care. And after doing some further investigation, we realized that it was these very specific populations: Black MSM, Black women, the Latino community, and our youth. These were the populations that weren't getting linked to care, that aren't in medical services. So the Damien Center, which is the largest AIDS service organization in the state of Indiana, received this grant, and they were told very specifically that in order to reach these communities, these very specific communities that are disproportionately affected by new HIV transmission rates, we had to work with organizations that had a proven track record of working with these very specific, very niche communities. So Brothers United was brought on board because we have a history of working with the Black MSM and transgender community. Women in Motion was brought on board because they have a history of working with Black women specifically. The Indiana Latino Institute has a history of working with the Latino community. And we had one other linkage to care specialist that focused specifically on our teen population. Next slide. So, what to look for in a linkage to care specialist? Now, this was on the previous slide, and I've purposely restated it because it's important. Are they truly reflective of the community they serve or what you think is acceptable? The reason why I said that is because if you look down at the photo collage, those are all photos of myself. I am a Black MSM, self-identified, 24 years old, so I fit the category of young Black MSM. So that passes the first test. I'm young and I'm Black and I'm MSM, so I do reflect the community that I serve. I have a bachelor's degree, but beyond that, I think what's also important is this person fully integrated into the community that you're wanting them to work with? Just because someone is a Black MSM does not mean that they're fully integrated into the community. This person needs to have strong communication skills, and they need to have a variety of communication skills. They need to be able to communicate horizontally, so with people who are their peers, people who are on their level, people who are in the community, people they serve, but they also need to be able to communicate vertically. And by vertically, I mean they have to be able to navigate multiple spaces, and that's why I chose a variety of those pictures. You see me at the top left, I'm at a ball. You see me in the middle, I'm at a conference. You see me in the bottom right, I'm at an old school skating party. So every day I don't wear a shirt and tie because that's not reflective of the community that I serve. So I have to be able to wear a shirt and tie, sit in meetings, be able to advocate for my clients, but at the same time, I need to be able to take off that shirt and tie, show that I'm relatable, show that I can walk in those same shoes, and it's important to be able to navigate those very specific spaces. Lastly, a positive reputation in the community is crucial because I can tell you this, a lot of times when I've worked with clients and I've received a referral, a client might tell me, you know, I was afraid to contact you, or I was a little worried or a little bit hesitant about coming to your agency, but I asked around and I asked a few people about you, and everyone that I talked to had positive things to say. So it's important for that person in the community to have a positive community reputation because they are the front lines for your organization. They will be working directly with clients, and you want clients to feel comfortable knowing that they can go to this person, knowing they can trust this person because they're already integrated in the community, and they're integrated in the community for things that are positive as opposed to things that are negative, people that are associated with drama, people that are associated with things that would make a client or someone that we serve not feel comfortable coming in our agency. So I cannot stress enough how important it is when you recruit your peer professionals to make sure, ask around, ask people within the community, do they have that positive reputation? Because they may seem positive on a resume, but in all reality, not so much in the community. And definitely, one thing that you cannot teach, but one thing that is important is you must have care and compassion for this work and for others because it is tiring. There will be moments when you're burnt out. And I wholeheartedly believe that in those moments, it's that care, it's that compassion that helps you to keep going, that helps you to continue to work with that client, to build that trust and to build that rapport. You have to have care and you have to have compassion. Next slide. So, what are the benefits of a peer professional model? So we just talked about what to look for, but what are some of the benefits? Why do I need to bring on a peer professional in my agency? Peer professionals have unprecedented knowledge and understanding of unique community challenges. To use the ball community as an example, I work very closely with care coordinators and medical providers, a client's entire care team. I may be the only person on that entire care team that's knowledgeable about ballroom life and ballroom culture. Talking to a case manager, a care coordinator, and the care coordinator is racking her brains about why this client isn't making appointments, why they always miss, why they're difficult to contact, why they don't have a steady address. And from a care coordinator's, case manager's perspective, when the client talks about ballroom, they're thinking a ballroom dance or a competition. They don't really understand the depth of the ballroom community, so they don't know that these clients are highly, highly transient. They may travel all across the country. They may travel from New York to Florida to California to Philadelphia within a month's time, and that makes it very challenging. So sometimes it is very beneficial to have peer professionals in place that understand this culture, that can work alongside the client and the provider to bridge that gap, to make sure that the client is receiving the best care, and to make sure that the case manager is knowledgeable on how to provide specific care for that person, so that the medical provider is aware how to provide specific care for that client. Another example is understanding pageantry and understanding that a large portion of the transgender community are involved in pageantry. A large portion of Black gay men who dress in drag are part of pageantry, and understanding that that's another access point. That's another way to conduct outreach. That's another way to understand clients. I know, not to paint any stereotypes, but I've worked with some clients who are involved in pageantry, and they may also do some commercial sex work. But it's a little different because they may go on tour, meaning I may travel to Miami to do a pageant, but while I'm doing a pageant there, I'm also going to be on tour. Well, they may tell this to their case manager. They may tell this to their medical provider, and to a medical provider or case manager, what does being on tour mean? You know, so being able to convey that to a medical provider, being on tour means sex work. This is the type of behavior that this person is going to engage in. If this person is going to engage in this type of behavior, how do we best protect them? You know, so it really is about knowing the very specific challenges that emerge for these communities. And the last example that I want to use is here in Indianapolis, we have seen a rise and increase in meth use among Black, gay, and bisexual men. And that, for a lot of people, was very shocking because stereotypically meth has been seen as a rule drug, or it has been seen as a drug that only affects a certain population and not necessarily Black individuals. The increase in meth use has been tied to the increase in syphilis cases here in Indianapolis. So the great thing about having somebody who's on the ground, who's integrated in the community, before the health department was aware of the crisis, before disease intervention specialists were aware of the crisis, we were on the front lines. We were talking to clients that felt safe with us, clients that felt comfortable disclosing their own meth use with us, and we were able to troubleshoot, to work with the county medical providers, the DIS, to create a very specific intervention and a very specific plan that was related and geared towards Black MSM, Black, gay, and bisexual men, and meth use. So that's a very specific example on where we were able to be ahead of the curve because of, once again, people being fully integrated into the communities that reflect the communities that they serve, that are on the ground, that are aware of the unique challenges that change sometimes on a weekly to a daily basis. Also, very quickly, just relatability. You know, clients are more able to relate with people who are peer professionals because they have shared lived experiences. And what that means for the client is we don't have to retell or repeat our story all the time. One thing that I like to practice is I like to practice trauma-informed care. So knowing that some of the individuals that enter our offices, that enter our spaces, a lot of them are broken. A lot of them have already been ostracized for being black, for being gay, for being just who they are. And understanding these challenges and understanding that sometimes having to retell my story about how I was victimized and how I contracted HIV, that can be very traumatizing for me. Having to retell every detail of why I'm homeless, reliving the fact that my family kicked me out of my house, is very traumatizing. So as opposed to having someone who is on the ground, who is reflective of that community, who understands some of those very specific challenges that a care coordinator may not understand because they haven't lived those experiences. So what I found is just being there means you don't have to tell me every single detail. I understand. I can relate because I've gone through that. And not only have I gone through that, I use myself as an example, and I use myself as the model of I've gone through some of the same challenges and obstacles and opportunities that you have. Let me show you what worked for me. Let me show you how I can help you navigate through some of the same challenges that I have. So it helps reduce trauma, and it definitely helps with relatability. And sometimes a small thing, once again, to talk about lingo and language, not having to teach a provider who I am, not having to teach a provider what does it mean to be a black gay male, not having to teach a provider what it means to be transgender and why I use words such as date popping or going on tour. A lot of times it removes that issue and it allows you to just focus on the client as opposed to teach me something about you, teach me your culture so that I can understand, and then I can help you out a little more. It just goes and it helps to really focus on the client more. Next slide. So, I cannot say that the peer professional model is without challenges, but I'm a firm believer that these challenges can be overcome. So the challenges that I have listed are a combination of some of the challenges that I've experienced personally, and then also some of the challenges and the pitfalls that I've seen other individuals face. One of the great things about Brothers United is that we are heavily integrated into the community, and that's why we've been so successful. But one of the drawbacks to that is we have not always prepared our peer professionals for success. So some of the challenges, limited experience and knowledge about HIV. My background, I had a bachelor's degree in English and sociology, no knowledge of public health, no real knowledge of HIV other than being a black gay male and trying to navigate HIV. So how do we combat that? Extensive trainings on HIV. And the reason why I say that is because you don't always have to choose someone who is currently working in the field. Sometimes the best person for this job may be someone who is unrelated, because you can teach someone HIV facts. You can teach someone about the systems of care. You can teach someone about insurance. You can teach someone about housing. But it's very important, because this prepares your peer professional to be successful, it prepares them to be knowledgeable, and it prepares them to be the best support for clients. So making sure that they're knowledgeable about HIV, making sure they're knowledgeable about treatment regimens, making sure they're knowledgeable about insurance policies, enrollment criteria, what's needed, making sure that they're knowledgeable about the housing process, every single housing option that's available for a person living with HIV, because as the linkage to care specialist, it's your job and it's your responsibility to be the glue between the entire care team. So you may be the person that's communicating with housing, that's also communicating with case management, just to make sure that the client is on the right track. So it's important for you to have that knowledge, because if you have that knowledge and clients know that they can come to you and know that they can trust you, it helps to build that rapport. Understanding professional boundaries and ethical dilemmas. This is very, very crucial for a peer professional who may not have had extensive training in social work, who may not know what professional boundaries are. So we did very specific trainings on ethics, and we completed role plays for how to reinforce those trainings, just to make sure that people not only understood what those ethical dilemmas and boundaries were, but they also knew what to do and how to handle themselves in case that situation arises. One of the most difficult challenges is living and working within the community, because you hire someone who is a peer professional because they are integrated in the community. They have access. They're aware of the spaces. So you don't want to stop that. You want your peer professional to still live and work in the community. But the challenge comes in, how do I, on Friday night, go out at a bar, have an adult beverage, but still be looked at as a respected figure within my community, you know? So it starts with setting clear boundaries and clear expectations up front. What is your agency's policy? What is very specifically allowed? What very specifically is not allowed? Like, we have policies and rules in place that say if you're belligerently drunk in public and it gets back to us, that affects your job performance, because once again, this person must be trusted within the community. And I've had this happen, very real examples. I've had someone come to me and say, you know, Terrell, I don't know if I want to work with this person because I saw this person being very drunk and being dragged out of the bar last weekend. So when this person comes to me and they're trying to give me advice and they're trying to encourage me, I look at them like a hypocrite. Like, how can you help me and you're not modeling what that should look like? So once again, to alleviate this problem, set very clear expectations, have very clear written policies for what's acceptable in public, for what you allow on social media, and then hold individuals accountable to those expectations. But I will say this, the expectation must be made upfront and it must be clear. Last, lack of emotional intelligence. So understanding how to be empathetic. You know, some clients tell us some of the most personal, intimate details about their lives, some things that they may not have ever shared with anyone else. How do I process that? How do I come off as being empathetic? So we did very specific trainings on reflective listening, on motivational interviewing, and on role plays. Next slide. So I wanted to talk very specifically about a couple of ethical dilemmas and boundaries that I've seen come about. So what boundaries must be set with a client? So for us, it was very clear, no engagement during personal time with people who are our clients and people who you work with. And that may be challenging, once again, with someone who's integrated in the community, because I might meet someone and they want to hang out with me. But if I'm going to maintain a professional relationship, it's just unacceptable. We have to maintain a professional working relationship. Although I'm a peer, if you're going to respect me and take me seriously in my role as a linkage care professional, then we must have boundaries. So no engagement during personal time. Strictly having a professional relationship, meaning no inappropriate sexual contact, no inappropriate flirting. It makes it very difficult to do your job when you see these things happen. And I must admit, has a client ever flirted with me before? Happens all the time. I'm a young person. I like to consider myself to be an attractive person, so that will happen. But the great thing about the training that I went through is what happens when clients make advances towards you. Because it will happen. So very specifically, you need to train your staff, your personnel, on how to address it. If you feel comfortable addressing it with that individual, address it politely, courteously, and be direct. If you don't feel comfortable and you need to get a supervisor involved, get a supervisor involved immediately. Make sure you document it. if you don't feel comfortable, if the advances continue to happen even after, sometimes you have to let the client know, if we're going to continue to work, if we are going to continue working together, this is unacceptable. But once again, it builds trust, especially in agencies that work with these very niche communities, because we want our agencies and we want our individuals to have solid reputations in the community. We don't want individuals to have a bad reputation, that we have inappropriate relationships with clients, because then folks don't want to come to our agencies. Folks don't want to trust me. So it's very important that we make that line very, very clear. Should someone I know personally be a client of mine? Sometimes you have to do that on a case-by-case basis. I would say more than likely it's probably a no, depending on the closeness of your relationship. But how do you have that conversation with that person, making sure that you refer that person to a separate linkage to care specialist that doesn't have that personal connection or personal attachment? I've tried it before. It doesn't work, because for the linkage to care specialist, you get too personally invested, and it no longer becomes your job. Now I'm taking it personal because you, as my friend, don't want to go to your doctor's appointment. So just to alleviate that, to alleviate any personal issues also that it may cause, any strains that it may cause on your friendship, I usually advise against working with clients that you know personally. And how do I respond if someone asks me, how do I know this person? Because it happens quite frequently in public. I may see a client may come up to me, hey, Terrell, how are you? Friends, how do you know that person? Oh, it's just someone I know. He's a friend of a friend. They may be a cousin. A lot of times with clients, I develop a code word with them. Okay, if I see you in public and someone asks, how do we know each other? Do we say we're friends? Do we say we're cousins? Do we say we went to the same school? So sometimes we get very creative, but also we just want to do that because from the very, very beginning, we stress the importance of confidentiality, we stress the importance of HIPAA, and we stress the importance, because it can be very scary. And I've heard this from clients. I want to think about my HIV when I come to my appointment, and after that, I want to take my medication and that's it. But if I see you in public, if I see you at a bar, I get nervous or I get scared because is he going to come up and approach me if I miss an appointment, like what's going to happen? But it really, really does help the person feel more comfortable knowing that I put your confidentiality first. Even if we're in public, we're going to see each other in public because I'm integrated in the community, but even if we see each other in public, I still want you to know that we're protecting and maintaining your confidentiality at all times, and you never have anything to worry about. That goes miles in building that client rapport and trust. Next slide. So just wanted to touch really, really briefly on motivational interviewing. Motivational interviewing is very, very important to building that client rapport and that client trust. Motivational interviewing helps you to ask the right type of questions in the right type of way, but the really great thing about motivational interviewing is that it teaches you how to ask questions to elicit a certain response from your clients, to make sure that when clients reach conclusions, when we're coming up with care plans, that it's client-centered and that it's client-directed. So motivational interviewing helps you to ensure that you're really focused on putting the client's needs first, that you're focusing on that behavior change, and that you're helping the client to work through their own ambivalence or feelings of understanding. So motivational interviewing is very, very important. It's a crucial tool, and that's why we're doing an entire webinar just on motivational interviewing. Next slide. So building client rapport, one person at a time. The reason why I put that on there and the reason why I wanted to highlight that is because I'm a transparent person. Brothers United is a community organization. We're very involved in the community, sometimes to our detriment. Sometimes folks are a little nervous about coming up here because of stigma. I don't want to come to a place where I'm going to see someone that I know. I don't want to go to a place where I might run into someone on a Saturday night who also works with me, you know? So sometimes what I found is it's working individual by individual, building that trust individual by individual, and as you grow, you'll start to see things like stigma decrease because of the trust you're able to build with individuals. Next slide. So next we're going to talk about first impressions, what it really means to have a person-centered approach, and what it means to have expertise and to be dependable for your clients. Next slide. So before we go into the rest, for the rest of our presentation, we are going to talk about Jacob, and we're going to use Jacob as a case study for implementing and utilizing some of these tools that we are about to go over. Next slide. So who is Jacob on the surface? The reason why I say on the surface is because Jacob walks into Brothers United one day, and this is all the information that we pretty much gather from him within the first 2 to 3 minutes of having a conversation. This is very surface level. This is the information that clients will most likely disclose to you, but building that client rapport and trust will help you go below the surface level. Next slide. Excuse me. So, why do first impressions matter? We talked about this and hit on it earlier, but we must practice trauma-informed care. And this is so important that I'm going to read it word for word for you on the slide. I might even repeat it a second time. But trauma-informed care is often described as a lens or framework to deliver medical care or, in our case, supportive care. Why? Because practicing trauma-informed care does not mean checking off boxes mindlessly or screening patients for emotional distress only to meet a requirement. A lot of us know what that means. We have an intake form. Have you ever experienced suicide, depression? Have you ever experienced homelessness? Have you ever experienced? Have you ever experienced? Have you ever experienced? And it's literally just going off a checklist. That is not trauma-informed care, because what we're doing is we're re-exposing these individuals to trauma. So we always want to be mindful that a person has probably experienced some form of trauma, and we don't want to re-traumatize people. So for me, the first impression is crucial in making sure that you don't re-traumatize individuals and making sure that an individual comes back to see you a second time. Because we know how it is a lot of times. We may meet somebody, they may come in for a reactive test, they may come in wanting to get linked to care, and sometimes it does happen. We may not hear from them for another 3, 6, 8 months, a year, sometimes even longer. So I really do believe that these things will help you make the best first impression, and they will help you ensure that our clients come back. So the goal of my first appointment is always this. The number one goal is to build that rapport. Make the client feel comfortable. Second thing is help the client feel safe. I never end an appointment without saying everything will be okay. Now, some people tell me, oh, Terrell, you shouldn't say that. You can't promise that everything will be okay. But I don't necessarily promise it, but I believe what I say. I believe that clients have power. I believe that Brothers United is an amazing resource for clients. I believe that if a client works with the individuals at Brothers United, we can help reduce their barriers, reduce their challenges. So I wholeheartedly believe that everything will be okay for that client. And sometimes, once again, people walk into our offices broken. They walk into our offices beaten down with low self-esteem, with high mental health issues. And sometimes hearing someone say, everything will be okay, having someone give you a hug and embrace can make the difference. It helps them understand that they have someone who is on their side. The last goal of mine, the last of the 3 goals, is to get accurate contact information and schedule a follow-up appointment. If I only hit the first two, then I'm satisfied. I always try to get good contact information, of course, because you want to follow up. But you don't want to walk into your appointment with the intake form. Hey, what's your name? Your name is Jacob? Here, Jacob, fill out this intake form. I'm going to schedule you for this appointment. Everything okay? Got any questions? Okay, see you later. Sometimes I might spend a good hour in an appointment just talking to someone, getting to know them before I even bring out the intake form, before I even talk about scheduling an appointment. So you really, really have to take that time. Small tip that I like to use, no cell phones or distractions. Make the client the center of your world for that moment. A lot of times, clients aren't the center of attention. A lot of times, clients don't have someone who is just there to listen to them. So I say this, make them the center of attention. Break up the isolation. Don't sit behind a desk. Everyone has something in common, right? Personal philosophy of mine, I believe that no matter who I meet on this earth, no matter what culture, no matter what language, there is one thing that I can find that I have in common with you. And if we have that one thing in common, then we establish common ground. It may be music, it may be food, it may be TV show. For Jacob, we bonded over music, you know, so it really does help to, once again, bridge that gap and show the peer element that's needed for this program to be successful. Don't immediately rush into talking about HIV. As I said, sometimes I may spend an hour on a conversation before I even talk about HIV. Is your environment comfortable? My office, the walls are painted green. We're fortunate enough to work in an environment that understands the physical space is important. So we usually have everyone in our office, we got to choose our office color, and we chose colors that reflected our personality, so it's all individualized. When you come into my office, you'll see a dim wall, you'll see dim lighting, and you'll hear music, because I want people to walk in feeling comfortable once again, because if I practice trauma-informed care, just walking into my office might have been a huge struggle, or it might have been a huge battle for you. So I'm going to make it comfortable. I usually try to have snacks, whether it's a bag of chips, a bottle of water. Sometimes it may be a microwavable meal, because a lot of times people come into our offices and they haven't eaten. So what do we do to make that person feel comfortable, to make them feel almost as if they're at home, to make them feel so comfortable that they're definitely going to come back because we're different, because we set ourselves apart. Don't be afraid to be the example. In a lot of cases, very specifically for Jacob, didn't talk about him in depth, but he came to us because he heard about housing, because he had recently moved to Indianapolis from Chicago. He had broken up with his partner, who was the reason why he came here. He had not been in medical care since moving to Indianapolis, had no medical insurance, and he was seeking employment. So this guy walked in down on himself, hard on his luck, beating himself up, just totally in a bad space because he blamed himself for making a wrong decision. So that was a case where I used myself as an example. You know what, Jacob? I've done the same thing. I've made bad decisions because of a relationship. It's part of being who we are. But guess what? Look at where I'm sitting at today. I haven't always been a linkage to care specialist. I haven't always been a program manager. But I went through these trials and tribulations, and I made it out onto the other side. So sometimes, I know a lot of times, we do not like to infuse certain aspects of our personal lives into our conversations with clients, but in a lot of instances, it's okay. Very specifically, utilizing the peer professional model, that's what we're there for, to be a model. So don't be afraid to use yourself as an example, because you can show a client what success looks like, or what overcoming obstacles, barriers, challenges may look like when they don't see the possibility themselves. Next slide. So, how do we accomplish a successful first visit. It's important to meet the clients where they are. That's both mentally and physically. So practicing trauma-informed care. Paying attention to verbal cues, paying attention when a client is uncomfortable talking about certain things and saying, it's okay, I understand. We can come back to that at another time, or we don't have to talk about that at all. We have to meet folks where they are. Also physically. Every first appointment does not take place in my office for various reasons. For things like HIV stigma, not wanting to come into an office that's branded the HIV testing place or the HIV care coordination site. So being able to meet people in public, being able to meet someone at the library or meet someone at Starbucks, it shows, okay, it's not about me, it's about you. Whatever is needed to do to help you out, I'm willing to do that because it's my job and that's what I'm here for, to help you out. So when you meet people where they are and you put them first, they're more likely to trust you because they know you really have their best interest at heart. Ask the right questions in the right way at the right time, and that really goes back to the motivational interviewing, understanding when is the right time to ask those questions, when it's appropriate to just move on. Next, focus on addressing the client's top barriers to medical care. This is very important because, once again, if we look back to Jacob said very specifically, I came here because I heard you have housing. Then Jacob revealed that he was a person living with HIV. Then he revealed that he was out of care. But at the root, Jacob walked in our office because he needed assistance with housing. So if I tell him, thank you for coming in to talk about housing today, but let's put that on the back burner. Let me do this intake form. Let me enroll you in insurance. Let's connect you to a medical provider first. Let's do all these other things. And then once you do what I need you to do, then I can talk to you about housing or complete a housing application. That's not putting the client first because the client's number one need when they walked in the door was housing. You have taken what you think is their number one need and superimpose it on them. So when the client walks out of the door saying, okay, I'm going to come back to talk about HIV, but they really didn't even help me out at all with housing, we miss and we lose a lot of people. So I think it's okay to say, okay, let's focus on your number one issue and these other things, but at the heart, the first thing I'm going to address is talk about why you walked in the door. And lastly, knowing of community resources to address compounding barriers to care. This is why training is so critical and is so important. So for Linkage to Care, we learned about every community resource, from resources for substance abuse and treatment, resources for food pantry, resources for shelters, domestic violence shelters. So literally, if a client has a need, they can come to us to help them, because clients want to come to a knowledgeable source. They want to come to someone who can help them navigate the system and figure out their problems. So it's important for you to be knowledgeable as a community resource, because as a client, if you're not knowledgeable, how can I trust you? How can I trust you? How can I trust you that you're giving me the best guidance, the best advice for my care if you're not aware of the knowledge, if you're not aware of community resources? Next slide. Most people want to be heard. How good are your listening skills? And I say that because I said it earlier, and I just want to reiterate it. A lot of our clients walk in beaten, broken, not knowing how to share their story, not feeling comfortable sharing their story. But what I found is that when people trust you, most people enjoy or appreciate sometimes just having someone to listen. So how good are your listening skills? Just from having conversations with Jacob, from utilizing motivational interviewing, asking those more probing questions, doing things like making him feel comfortable, making him the center of my universe for that hour and a half, 2 hours that we were together, his walls started to drop. And I started to learn more things about him during that first appointment than just what was on the surface. I learned that he experimented with recreational drugs from time to time. He had done some sex work to manage, to just get by from a day-to-day basis. Has a history of mental health challenges. He said something very subtle, like, yeah, I dealt with depression before, but I'm good now. That was it. I've dealt with depression before, but I'm good now. So then my question was, okay, well, what do you mean by dealt with depression? Was it self-diagnosed? And then he started to say, well, no, I saw a counselor or I saw a therapist. So then we were able to talk about, okay, some more things that were very specific to his mental health. But sometimes we have to listen and really take the time, because that was one of those things where he just mumbled it. And if I wasn't paying attention, if I was sitting behind my desk typing or just trying to fill out a form, I might have missed that. But what are the other things about Jacob's story? Because Jacob is more than just HIV. He's more than just his current situation. So Jacob aspires to be a writer. He wants to go back to school. He has a close relationship with his grandmother, and he loves Beyonce, Rihanna, and Fantasia. And those just happen to be three of my favorite artists. So we were able to bond and talk about so many other things beyond that. And the really cool thing about it is when Jacob gets in the car and we're on our way to a doctor's appointment, I know he loves Beyonce, I can play Beyonce, and we're in there, we're jamming, we're having a good time, and we're building that rapport and that trust. I'm getting to know Jacob a lot more than just what was on the surface. So when you do that, when people realize, okay, we have these conversations and you actually listen and you actually paid attention. After that first appointment, you remember that I love Rihanna. You remember that I have a close relationship with my grandmother. So you asked me, how's your grandmother? Have you called her and checked in on her? That shows that you're really paying attention, that you're really listening, and that you value someone's time and what they say. And when people feel valued, when people feel appreciated, they're more likely to trust you as well. Next slide. So, next slide.
Sorry, I'm coming. Sorry.
So, once trust is earned, you must do the work and stay committed. So what does that look like? So we talked about addressing the barriers and challenges that a client faces. Next slide. Because if a client's basic needs aren't met, how do we expect them to be successful? How do we expect them to go to a medical appointment? How do we expect them to have a positive relationship with their medical provider when that's the furthest thing from their mind? Next slide. Next slide. So you have to understand the challenges of engaging a client. So for our clients, lack of transportation, forgetting to go to appointments, inability to pay for treatment, and unsure of where to obtain HIV care. Now, I want to highlight and point out that these were self-reported barriers, and these were barriers for the program data. But when I drill down and I look very specifically at my clientele, the people that I worked with, their number one barriers were things like lack of transportation, lack of employment, lack of housing. Mental health was a huge concern. 60% of the clients that I worked with had some form of either self-expressed or previously diagnosed mental health condition. And then also substance use was very huge among this population. Next slide. And that's important to highlight and to point out, because when you're building client trust and you're building client rapport, clients have to know, once again, that you're putting them first, that they're centered, and that you're working towards helping them remove their barriers. So once clients feel that you're working for them and they start to see that progress, they start to attend medical appointments, they might find employment or find housing, then they're more likely to trust you, because not only do you say, I'm going to help you, but you are consistent and you're committed, and they start to trust you, and they start to do things that show that they trust you. So the reason why I put this slide on here, one that says we are moving, is to show that once we're moving in a positive direction, but it's also to show very literally, I've had clients call me on a whim, Terrell, are you busy? I say, well, no, I'm not too busy right now. Well, I just got evicted from my apartment. And then sometimes I'm like, man, why didn't I say that I was busy? But if I would have said, oh, I'm not busy, but now, okay, well, I'm not busy, but I still can't help you. You need to call this person. Clients feel like, okay, do you really have my best interest at heart? So I've literally gotten in my car, driven to someone's apartment, packed up my car 3 or 4 times, and helped that person move. But for that client, that meant more to them than taking them to a medical appointment. That meant more to them than helping them get on insurance, because they felt like that was something that I had to do because it was my job, and if I did it and I did it well, I got all the credit for it. But those things are things that you don't put in a grant report sometimes. Those are things that you aren't always able to quantify as a service, but it really does help to build that client trust and rapport, because it shows the client that I have your back. I'm willing to load up my own car and help you move, do physical labor for you, because I care about you, once again, holistically as a person, as opposed to I just care about you as a number. Next slide. So how do you know when trust is gained? You become a crisis manager. Like in this case, where the client just calls me, you become the crisis manager. Sometimes it's great because you feel great that clients trust you, but then sometimes it can also be detrimental because you may not have all the answers, or you may not be the best person to provide them with that type of support. So it's important for you in those instances to just understand that you're not the expert on everything, and to set boundaries, and to understand when it's important to refer back to the care coordinator, and when it's important to refer back to the medical provider. They begin to get personal, sometimes too personal. My favorite story of someone that got too personal was I had a trans client who was experiencing some side effects from some black market surgery that she had gotten done on her breast. And then she came in, I think I'd only known her for 3 weeks, and she said, Terrell, my boobs are hard, feel them. And then I said, whoa, that's like very, very personal. But those sometimes are the things that let you know, okay, that was too personal, but that client trusts me enough to just say, hey, these are my boobs, how can you help me out? You know, it's a strange story, but it's the best example of what it means to be too personal. And even then, once again, it's okay sometimes to say, okay, some things are a little too personal. I may not need to know every intricate detail about your life. Some things I don't want to know. Another great example is they begin to reveal mistrust of the medical system. Going back to Jacob as an example, as I began to work with Jacob over a longer period of time, he started to reveal why he is no longer active in mental health treatment. Stigma that exists within the black community around mental health. That was one reason. And then also he really, really hated his medication that he was on previously, and he didn't have a great relationship with his provider. So a great example of how we're able to leverage the trust that we've gained with the client. In Jacob's case, I was able to say, okay, Jacob, well, you may not trust this very specific mental health provider, but do you trust me enough to know that I will refer you to the person who's best for you? Okay, well, thank you. Are you willing to go to that person? Okay, thank you. I'll go the extra mile and I'll sit in the appointment with you because I know that you're going to feel uncomfortable. Okay, now it's time to start talking about antidepressants. What are your fears? Okay, your medical provider told you that antidepressants have changed over time and they don't have as many bad side effects. I can vouch for that because I've seen other clients of mine that are currently on antidepressants, and it's helped stabilize their mood. So that's a really great example of when clients reveal their mistrust for the medical system, where I'm able to step in because of the trust that I've already built with that client to say, you may not trust the mental health system. You may not trust the medical system, but you trust me, and you know that I work close enough with these individuals that I'm going to refer someone to you that has your best interest at heart. And then lastly, probably the best example of when trust is gained, word of mouth spreads. As I said, HIV stigma is huge, in particular in the Black community, Black MSM, Black LGBT community. Stigma is huge. Not many folks want to talk about their HIV status openly. So for me, it's always great, and I always know the program is working when I have someone who says, hey, my friend is out of care, but I need to get him linked. Can I call you? You know, that really does help, and it works tremendously. I would say for the latter part of our program, the bulk of our referrals came from word of mouth, came from, hey, you're out of care. I know this really great guy who will remind you about your appointments. He'll pick you up. He'll sit in your appointments with you, and he'll even take you home. Can I refer you to that person? So that's what trust looks like for me on an individual client basis is, one, getting direct referrals and also indirect referrals. A great example, I was at an event last week for National Get Tested Day, and I had a guy come up to me who wasn't even there to get tested. He just came because he saw a flyer and they were going to have live entertainment. And someone I know loosely from the community, he came up to me and he said, hey, I didn't know this was that type of event, but I'm glad that you were here because I'm out of care. Can we talk? You know, so a lot of times, if you have a good reputation in the community and people are just talking about the good reputation that you have and the positive work that you're doing and the results that they're seeing, other people sometimes just listen and they might come to you directly as well. So referrals are a great way to understand when trust is gained. Next slide. So, how do we leverage trust? We help clients feel more comfortable going to a medical provider. So having a close working relationship with all of the providers in the city, that way I'm able to refer clients on a client-by-client basis so that a client knows I'm going to refer you to this medical provider because I feel like this will be the best person for your situation. I feel like I know your attitude. Some clients I know your temper. This place may be a little more forgiving if you have an outburst, you know? So sometimes it's very, very specific, and it's helping the client feel more comfortable going to that medical provider. It's sitting in an appointment with the client and helping to bridge that gap, helping to understand that medical providers aren't judgmental. Medical providers need to know this very crucial, critical information to make sure that they are providing the best possible care and service for you. So it's important to talk about if you miss your medication. It's important to be honest with your provider. If you don't feel comfortable being honest right here in this moment, do you give me permission to say it for you? It's important to talk about if you are using substances with your HIV regimen because that can affect your treatment. That can affect the efficacy of your medication. So making sure that I use myself to bridge that gap to help the client communicate better with the medical provider because one day I won't be there. I will not be able to sit in every medical appointment. So it's helping to train not only clients, but it also helps to train medical providers, being able to say to a medical provider, do you understand what the client just told you? And that really does help. Also, a great example that I use with Jacob is breaking down mental health stigma, being able to use myself as an example, being able to encourage clients to seek mental health treatment because, hey, I've gone through tough times. I lost a parent. I lost a grandparent. Within 2 years, my entire support system, I had to sit down on a couch and talk to somebody until I felt better. So being able to use myself as an example, once again, to help the client feel more comfortable seeking mental health treatment. And then also helping with medication. A lot of clients are terrified of side effects still to this day, even though side effects aren't as bad as they once were. Being able to say, hey, I have clients who are on this regimen that aren't experiencing side effects. Don't just take the provider's word for it because it's their job to prescribe you medication. Take my word for it because you trust me and because I work with individuals who aren't experiencing complications. And also to help clients understand when medications change. I had a client come into my office and he didn't understand why his doctor was changing him from a triplet to Genvoya. So being able to break that down, understanding the terminology, but being able to relay the terminology so that it's not overwhelming and so that it's not over a client's head. And then being there during the first pill, I could not stress how important it is to make sure that the client takes that first medication, making sure that they have support, but then also making sure that they continue. So just checking in and making sure that clients are being medically adherent. Next slide. Next slide, and we've already talked about Jacob a little bit throughout the course of this presentation, but just to summarize and then to open the floor for questions, Jacob's plan. So after Jacob came in to that initial appointment, after I got to know him a little bit more, after we utilized motivational interviewing, after we helped him understand his own barriers for care, we created a 6-month plan to address those initial barriers. That 6-month plan included getting him into medical care. So we assisted him in re-engaging with medical care by connecting him to a medical provider, making sure that he had insurance. We provided transportation and support during the medical appointments until he got to a place where he was able to attend his appointments alone and independently. We assisted with job search and resume because for Jacob, his issue was housing, but he also had a huge employment issue. He wasn't employed, so how was he going to be able to sustain living anywhere? So we were able to connect him to an employment program, help him find a job, provide him with transportation to the interview, help him apply for HOPWA assistance, help him re-engage in mental health, and also connected him to some support groups to help him discuss his substance use. Next slide. So for Jacob's results, he did re-engage in medical care and was prescribed antiretroviral therapy within 90 days. We got him employed, we got him virally suppressed, and then he gets arrested for commercial sex work, prostitution. Because what did we do? We got him connected to medical care, we got him virally suppressed, we got him a job, but unfortunately the job was not making a livable wage. It was a low-paying job. He still did not have housing because of a variety of issues, him not being able to sustain his apartment based on his current income. So he was still doing some sex work to supplement his income, got arrested, finally decided to stop his sex work because of fear for prosecution for non-disclosure. After that, we saw his viral load spike once again, and that was due to him being incarcerated, going without his medication, just having a really rough time once again. But I pointed that out because a lot of times we tell these stories and we tell success stories and it's almost like it's a straight and narrow path to success, but a lot of times it takes a lot of curves, and as a linkage specialist you need to be resilient. So for him, once we were able to get him stably housed in a housing program, after 9 months, we saw him reach viral suppression once again. But that goes back to the very thing that we talked about in the beginning was it was important to put the client first, to make them centered, and to address their needs to make sure that they can sustain in medical care. So I think Jacob serves as a good example of why it's important to listen to an individual, understand what's more than just what's on the surface, and then to build that close relationship, and then to really leverage that relationship to build a better relationship with the provider, to increase communication with the provider, and to increase medication adherence and to help our clients reach viral suppression. So now, thank you very much for listening to my presentation, and I would like to open up the floor for questions.
Thank you, Terrell, for a really fantastic presentation. We do have a couple of questions banked here, and some of them just kind of have to do with vocabulary. So we have one listener who wanted to know what date popping means.
Yes, so date popping, going on tour. Some people might call it working the sites. Some people might call it escorting, form of commercial sex work.
Mm-hmm.
Or prostitution, because some people aren't even familiar with the term commercial sex work.
Right. And then we have a participant who had a question around self-care and said that you are definitely going to the max and giving all you have in terms of quality services for Linkage to Care. What do you do to maintain your sense of self so that you can be renewed and replenished to keep doing this work?
That is a great question. I have to be honest, I did not learn the concept of self-care probably until about a year and a half, almost 2 years into the position. So at that point, I was burnt out when I learned about self-care because it's really intense work and you're really working very closely with people. So your emotions get tied up and you get invested. So it's very easy to become overwhelmed. So what I like to do is we actually had a training at our office on emotional intelligence and how to understand some healthy ways to de-stress. So now I try to do things like make sure that I get a pedicure, if I want to get a massage, turning off my phone, feeling comfortable turning off my phone, not working so much after work hours, actually taking vacation time that I have that I didn't really use. And I think now that I've transitioned into a manager position, it's important for me as a manager to create a climate where self-care is promoted. So it's important for me, as an example, we have a new Linkage to Care specialist. He's been on the job for about 3 months, and he's already starting to get emotionally taxed. So telling him, hey, take a couple of days off. Like actually take a couple of days off, and then not emailing him on his day off, not calling him on his day off, actually allowing him to have a day off. I think that's very important because I think a lot of times we don't set the culture or the climate. We look at vacation days as easy days, or then you come back to work and you're stressed. Now I have all this work to do, and my supervisor is on my neck about producing a report. So do we really create a culture where we practice self-care? I also think it's important for people to have an outlet to talk. So whether it's your supervisor, whether it's a peer that you work with, having an outlet to talk as well. So creating a culture, taking vacation days, and understanding things, healthy ways to de-stress, and intentionally doing those things to de-stress.
Those are really good strategies that hopefully folks will find helpful. We've talked a little bit, you and I, Terrell, around the readiness check, or that getting a good sense of when your patient is ready to begin care, specifically treatment, and you talked a little bit about during the presentation that moment when one starts taking their medication. And so we had a participant who wanted to hear you talk a little bit about that, like how do you assess readiness from client to client to begin specifically taking HIV treatment?
Gotcha. So the goal-setting document, and I can share it, is usually pretty helpful. So after we go through kind of the list of barriers and challenges for an individual, what I usually like to do is say, okay, how do you eat an elephant? One bite at a time, and you have to take it, one step at a time. So helping the individual identify what are your top 3 barriers, and then let's create a rough, loose timeline that holds us accountable but also gives us some flexibility for life to happen. If life shows up, we have some flexibility. So I think doing that helps people prioritize, and really it just becomes a seamless process. So for some people, they indicate within those 3 goals, it's my goal to get in medical care and start HIV treatment. So for those individuals, we immediately start to work on it. But for some, it may be, okay, after we've made progress in your first 2 goals, your first 3 goals, or after we have actually accomplished those goals and you have a little more headspace to think about other things, okay, now let's talk about starting HIV treatment. Okay, so when we met 3 months ago, you said that your goal was to find housing, get a job, and find a doctor. Okay, so now you're on HOPWA, you have a job, you're seeing a doctor. Are you ready to talk about treatment now? And I think for me, just so to sum it all up, use motivational interviewing to help clients identify their own barriers, help them to prioritize, check in, and then as barriers are reduced, start to think of other ways to keep them engaged and start to think of new goals to accomplish.
And the last question has to do with the acute meth outbreak that you had mentioned earlier in your presentation. A participant wanted to know if the meth outbreak is that something that is new to the public health community, or in your experience have you found that Black communities specifically in this area in Indianapolis have always used meth, and specifically in terms of them modeling public health interventions to assist?
This is something that is definitely new for the community. I know that it's new because I've said in the meetings, I'm on the MSM subcommittee meeting, MSM, Health Services Coalition, I'm sorry, the name changed. And so we have someone from Bellflower Clinic who does all of our disease tracking. And they come and they do presentations every month on syphilis updates, and they report on individuals that report being drunk or high during the time of an STI, STD transmission. And from their data, it's definitely something new. And we were able to, because of some unique work that they're doing with social networking strategy and some of the information that we had, we were actually able to pinpoint it to one individual who was the epicenter, who was a property manager at a building that we house a lot of our folks who are living with HIV who may have HOPWA. So a lot of our folks, we refer them to that building. So what we were finding was the property manager at this specific building was intentionally recruiting young Black gay men for sex parties, and he was engaging them in sex parties with meth. And it literally spread from this one person bringing it into the community and then being able to trace it and map it out. So it's not something new to the public health community, but it's something new to the Black, gay, and bisexual community.
Okay, in Indianapolis, in that region specifically. Okay,
yes,
cool. I feel like we could talk forever, but I know our time is limited. Terrell, I want to thank you so much for joining us for this His Health Webinar Series installment. Terrell's contact information is up on the slide. You can reach him at any time. We'll also forward the PowerPoint materials to you, and this webinar, as well as the recording and the PowerPoint, will be archived on hishealth.org, which again will go live August 2016. Terrell, we want to thank you so much again for joining us. Enjoy your day, and we will see you on July 8th. For a webinar with Abby Shapiro from Eskenazi Health, formerly of Damien Center, correct?
Yes.
Awesome. Sounds great. Thanks for joining us.
All right. See you soon.
Bye, everyone.